Hello everyone, I'm Dr. Angela Mattke and you're watching Ask the Mayo Mom on Mayo Clinic's Facebook Live. Twice per month I host a show where we discuss pediatric health topics with top experts from Mayo Clinic Children's Center in Rochester, Minnesota. If you're joining us for the first time, we want to hear your questions. So please post those relevant questions about today's topic, which is pediatric cataracts. Joining me today is Dr. Erick Bothun, who is a pediatric ophthalmologist at Mayo Clinic Children's Center. Dr. Bothun is a professor of ophthalmology at Mayo Clinic Children's Center here, where he's also a world-renowned expert in the treatment of pediatric cataracts. He treats children who also have a wide range of problems, from things such as lazy eye, also known as strabismus, to glaucoma and eye trauma. Dr. Bothun, thank you so much for joining us here today.
You bet. It's an honor and privilege to share.
How did you get interested in pediatric and congenital cataracts as being one of your specialty areas?
I think, like many ophthalmologists, the gift of doing an intervention to restore sight is profoundly impacting during your training. Unfortunately, the subset of children that have cataracts are much smaller in terms of our practice. So as a pediatric ophthalmologist, there's a plethora of things you treat.
Right.
But that aspect of providing care in a way that eliminates a problem that has meaningful long-term effects, and with that impact, hopefully blesses and complements a child's life long-term, I think steered me into continued research and investigation and care in my practice.
And you've traveled all over the world talking about cataracts and stuff, and we'll get to some of those research areas later in our show, but let's start with what exactly is a cataract. Let's define it, because I think there's some misconceptions sometimes out there that it only happens in people in elderly ages.
So a cataract is, as I have a model here I can show, is a haziness in part of the optics of the eye. And so if an eye itself, you can think of it like a camera, and there's lots of ways of describing that, but light comes through the camera in the front and gets focused, and the image has to get picked up on the back. And the back of the eye has the retina that may come up later in the talk, and the nerve that sends the images to the brain. But right behind the pupil, and when we look in an eye, you don't see it because it's dark in there, but right behind is this lens. And it sits tucked in, hidden. It's the shape, I oftentimes refer to it as a plain M&M. It's kind of a disc, and it has a width that focuses. And in our life, that slowly gets hazy as we get older and older. So as a senior citizen, we can all expect that our vision might not be the same as when we're 20, and it might need management. Unfortunately, it requires surgery to address that haziness. Children, unfortunately, in certain situations, develop cataracts much younger than our grandmas and grandpas, and that affects them in unique ways. And so the cataract is a blockage or blurring of the light coming into the eye.
Okay. Well, what causes the cataracts to develop in young children so early on, as opposed to, a lifelong exposures to light and focusing and doing the things that the eye and the lens are supposed to do?
The biggest subgroup is genetic.
Okay.
There are numerous children that have cataracts related to a family history of similar eye conditions. It can be in the presence of other genetic syndromes such as trisomy 21 or other congenital anomalies. So many children are born with lenses that are inherently doomed or predisposed to developing a cataract. There's another subset of kids that would have had normal development, but it's interrupted by some sort of infection, and there are maternal infections that a baby will acquire, and one of the consequences of that will be damaging the lens or the eye structure. And then lastly, there are a host of things that as the child ages, inflammatory problems, trauma to the eye, conditions where radiation or steroids might be used, and those effects change the eye in a way that can elicit a cataract. And then with that, unique things such as Marfan syndrome and other anomalies that change the whole architecture of the eye over time. So there are some early things, right, from a baby's newborn stage to things that can be acquired through the school age years and impact the eye.
Okay. What is actually developing when the cataract is becoming, or the lens is becoming cloudy and developing a cataract?
So the lens itself in that M&M shape is full of fibers that need to be packed and shaped in a way that allow clarity. And you can think of it like a box of pencils. You look in the box and they're neatly stacked and they're just the right number in that box. But if you dump them on the table and push them together, they're not packed the same. And the lens structure in either congenital status or in infections or in metabolic abnormalities, the packing and the size of the fibers change, and oftentimes the fluid concentration of the lens change. And it's all fancy stuff to say it gets cloudy.
Right.
And with that cloudiness, the vision's impaired. And with that impairment comes consequences to vision development, to alignment development, and other side effects that are sometimes what the family notices that elicits something's wrong with my daughter or my son. Let's go see somebody.
So in addition to your diagram here, we've got some pictures of a cataract here. So let's take, why don't we take a look at, why don't you explain to us what we're seeing here? It looks like a bunch of different types.
It is. These are kind of a collage of different examples of eyes that have haziness at that lens surface. And some of them are associated with other structural things. The lens is so closely related to the iris that commonly the iris can get sticky, or kind of, you see these little string-like attachments of the colored part of the eye called the iris. But what you see here too is that the blockage can be of different density and different size. And when the light is shined in, some of these pictures look red or orange, and that's no different than red eye in a camera.
Right.
And when the back of the eye glows orange, you can see the cataract illuminated as blocking that. And some cataracts are big and some cataracts are small. The next slide we might reveal that you can have a cataract like the one on the left.
Yeah.
And a baby will be born with that type of cataract. It won't be associated with potentially any vision impact in some children. And we monitor those children, but oftentimes they never need surgery and will have 20/20 vision. The child on the right will have profound impact in terms of their ability to develop vision, and if it's not managed appropriately, can have blinding effects and impacts on the rest of their life. So the size and location and morphology, or the shape of that density, matters significantly in terms of how quickly and the types of intervention we would do.
Okay. Let's get to that in a second.
Yeah.
But how can having a cataract in early childhood or congenitally right after birth, how can that affect their vision long term? That's a question we just had from the audience come in.
So cataracts in senior citizens are causing a blur in a system that already knows how to see. We spend our life with good vision. The blur slowly takes that away, and an adult will experience blurred vision. Once you go in and take out that cataract, the brain is waiting to see clearly again. And people love their adult cataract surgeons because they get their vision back overnight.
Right.
Unfortunately, in infants, as a newborn, any mom can testify, it takes a while for a baby's vision to develop. They don't instantly respond to parent's face or the room right away. And that's not just eye growth, it's really brain development. If you don't allow each eye to deliver a clear picture to the brain in the first months of life, the brain gets stunted. So a cataract that's severe, that is left in place from birth many, many months, can be handled perfectly, but the child may always have severe vision impairment because the brain missed those early milestones to develop vision. And what we call that brain stunting is a term called amblyopia. So the cataract, the diagnosis of a cataract comes with the need to diagnose risk factors for amblyopia, and the management of the cataract primarily is meant to minimize amblyopia.
Okay. So you said manage risk factors for the development of the cataract. I imagine that's going to involve another team of people depending on what the diagnosis is. Who are some of the other physician groups or other types of providers that you'd be working with these patients?
Here at the Mayo Clinic, we strive and I think deliver team approaches to care in a phenomenal way.
Right.
So children with congenital anomalies or conditions such as Marfan syndrome, it will be managed in along with the cardiac services, the primary services, connective tissue aspects of their disease are managed as a group. Okay. And I will manage their ocular condition. And another big group that gets managed as a family really is our children with inflammatory conditions. Juvenile idiopathic arthritis and related conditions cause inflammation throughout the body. And it that inflammation can affect the eyes, and you need the care with the rheumatologists and the pediatric teams to suppress inflammation and help the eyes just as much as it helps the rest of the body.
Okay. In the earlier pictures where you showed the two different cataracts, the really small one versus the large one that could severely impair the vision development of that child, how do you determine if surgery is needed and when it's needed?
If the surgery needed is the biggest question.
Yeah.
Because if the surgery is needed, the sooner the better.
Okay.
The assessment that we do in clinics with a team approach, I love all aspects of care. I have orthoptists and technicians that help us not just me examine the cataract, but really assess the child's functioning. And there are clues of when that functioning and vision development is being derailed.
Okay.
In addition, the exam itself, with experience, you develop an understanding of which cataracts are going to need to come out and which don't. And the majority do, but it's a blessing when you can manage this without needing to take the child to the operating room.
Okay. Are there different classifications of the cataract, or is it just one lump diagnosis? And will that kind of affect how you go forward with treatment?
And that's a great question. The morphology or the shape of the cataract is profoundly different and in different conditions.
Okay.
So a child that develops a cataract from a steroid, steroid effects on the rest of the body, even managing things like asthma, that type of cataract will look totally different than a cataract from say a severe condition related to other anomalies and cardiac defects. And with those nuances, some of the opacity are more problematic than others.
Okay.
So understanding the etiology and the morphology helps us.
Absolutely. We have a question from the audience. They're asking, what are the risks that involve removing a cataract in a child and a young child?
Great question. Let me go back to this model and describe just first maybe how we approach surgery.
Yeah.
So if we have a child of an age that is critical for development, or even beyond that in a mechanism that the vision's being blurred, we know that we have to manage it and bring clarity to the eye. Cataracts are managed through very small incisions in the front of the eye, much like in a senior citizen. The tissues handled differently. The optics are different. The eye's still growing. So unlike an adult cataract surgeon where grandma's eyes aren't growing anymore, you know exactly what lens to put in and you get beautiful vision right away. A child's eye is still growing and you have to sometimes put in a lens that child statistically will grow into with the best chances. Okay. So these that are done. I have a picture we can maybe turn to, of a surgery series. And what it shows here is steps in a surgery, and I discussed the lens being much like an M&M. And you can imagine it where here's an instrument, and the instruments continue to change and upgraded, but it's opening up the front of the M&M, and then you suck out the chocolate, essentially. In this case,
the chocolate isn't good, right?
The chocolate's not good. Okay. So the chocolate being the hazy lens and the rest of the lens itself, because once you touch the lens, even the clear parts become hazy. Okay. And then you've given the child a clear window to the back of the eye. Oftentimes, in this case, we're leaving the lens without implanting a new lens, but it's through these small incisions, typically in front of the colored part of the eye, with the eye well dilated, that we're going down onto the top. There are other techniques that are sometimes indicated where you go behind the eye. There are times we need multiple specialists to coordinate the care because of the intricacies of a child's cataract. But this is an example. Now, we can go to the next slide where we have an intraocular lens displayed. Oftentimes, in older children, it is the best choice to put a lens in to not just restore vision, but at the time, but let the child grow into optics that'll be ideal long term. And so this is an example of a cataract on the left. You see they all look a little different. It's like frosted windshield in the morning in Minnesota. And I've opened up the lens and taken out the chocolate, and then I put in that new lens. Okay. And the lens is shaped like a disc with arms that go out to the side, and it heals in place, providing optics that are clear. And after surgery, that iris would come back down to a normal size. The light wouldn't be direct, so it wouldn't be a red reflex, and it would look, it'd bring clarity and an ability to develop vision. So going back to the question, what are the risks?
What are the risks, right? I suppose it depends on the surgery, right?
It depends.
Yeah.
It depends on a number of things, including the age,
Okay.
including the complexities of the eye. Some of those eyes in the earlier photos were much more challenging looking in terms of structure. So the more the rest of the camera is healthy, the less risk there is. But just like any surgery, there's risk of infection, there's risk of bleeding, there's risk of structural damage in some way, and yet much like the adult cataract world, cataract surgery performed by individuals that are well capable, it's a beautiful process to be part of. It's probably the cases I enjoy most to do. The real complications and challenges in kids, however, are not actually the day of surgery so much as the monitoring and care after. One of the big things that happens in some of the infants after cataract surgery is a condition called glaucoma. Not surprisingly, a child that has heart surgery as an early age may grow up and have high blood pressure because the heart's not normal. And in the same way, an eye that has cataract, you do surgery on that eye and it almost ages it or changes it in ways that aren't fully understood, and ongoing research trying to address that creates drainage system abnormalities, and many of these kids will develop glaucoma later in life. That's managed with drops or surgery, but if it's not detected, it's a problem. That's number one. A number risk would be developing a misalignment. You can have laziness of the vision itself. That's called amblyopia. But if the eyes aren't developing well in terms of how they move, strabismus or misalignment will later need care. And then any sort of inflammation that the lens itself isn't stable or is rubbing in some way, or structure damage to the back of the eye called retinal detachment, are things that need close monitoring and care if they occur. The blessing is, for the most part, those are very rare. So it is important to diagnose it and address it well if it needs to be done. Have teams that can screen and look for those risks. And yet I think most families get through it and appreciate what a rewarding thing it is to see in their child as the vision develops. So
you mentioned close follow-up after the surgery. What should a family expect for? Are they going to need to see you every week, every month? I'm sure it's going to be very individualized, but generally, what is the follow-up like for their whole childhood?
Most children after cataract surgery are cared for much like an adult in that respect, where we start with drops. They're seen the next day, and at 1 week and 1 month. That's tailored based on if they have risk factors. Oftentimes in the first 5 years of life, the visits are every 3 months to 6 months because we're doing patching or glasses or other interventions to maximize their outcome. Once school age hits, the patching frequency drops dramatically or stops. So a child, once they hit school age, usually it's annual exams unless they have other complications or abnormalities.
Okay. How long is the surgery itself last, and what's the recovery time like for their child? What can families anticipate?
Surgery itself is probably twice as long as an adult cataract. Some of the adult cataract surgeons are amazingly efficient. An average surgery would typically be about 30 minutes for the actual hands-on surgery with me. But the anesthesia process for a child to have it done is more like an hour and a half to 2 hours. Going to sleep and waking up an infant is a big deal. In addition, a lot of the testing that will be done for an adult cataract care is done when the child's asleep. So I need to bring in all the instrumentation, have the entire team ready to equip that child with whatever we find or observe in that exam under anesthesia. So between all of those steps, it's usually an hour and a half to 2 hours. The child goes home and for the most part feels like a scratchy, sandy, gritty feeling, but not a lot of pain. So there's that management of protection that they shield it for a couple weeks, especially in these active 3, 4, 5-year-olds. We don't want these eyes bumped while they heal. Beyond that, especially after the scratchiness goes away, it's just optical care and managing with patching, which I think most families look back and have great memories of the years and months of patching children that have asymmetric vision. If their vision's symmetric, you don't need to patch so much. But if there's one eye cataract and the other eye's normal, that's where we manage that amblyopia with patching long term.
Which eye are you going to patch, and why do you patch? What benefits is that going to bring?
The brain is so good at shutting off any eye that has a defect. So these babies that are born with cataracts in one eye, their brain essentially isn't using it from the time of birth. And even after cataract surgery, the other one's so perfect, the brain uses that when it's dead. So in infants, the management is oftentimes up to about half the day, that you'll cover the good eye and force the brain to use the weak eye, to say, fine, you use the right eye. So let's say if the cataract's in the left, for half of the day. The rest of the day, you got to use your left eye. And that is reduced as the child gets older. Most families, we work with them and give them techniques and advice on how to do that. And yet that's the yoking, tough work that families get to do as we achieve vision. And yet the reward comes when they get to be 3, 4, 5 and are reading eye charts, and families get emotional about what this battle's been and the rewards we get to see.
I bet. How about, will these lenses last their entire lifetime, or are we looking at needing to replace them like you would replace a joint?
That's an area of continued care. I'm actually speaking on that on the upcoming conference, because these lenses have been used for about 25 years.
Okay.
The first lens was implanted in 1950-ish, but in pediatric population, it didn't become more commonplace until late 1980s and early 1990s. And part of that's the techniques improved so. What that means then is our modern lenses, even though they continue to get better, haven't been in for a lifetime. So we usually implant that lenses in children, and with the communication of the family, is there someday that lens may haze up itself, and because it's a piece of plastic that even as beautifully tolerated as the eye leaves it in there, we don't know. No one's ever lived with one for 80 years. So when you put one in a baby, we have that conversation. The good news is, if they ever need to swap out the lens, it's oftentimes more straightforward than the original cataract surgery. So at the age of 45, if it needed to be managed, it'd be managed much like an adult cataract, where that artificial one is removed and you slide a new one back in.
Okay. Can you tell us a little bit about the research that you've involved with? And that's been looking at the different types of lenses, I understand, that have been placed in kids. And it's been a pretty big study that has had a profound impact on children with cataracts.
On care?
Yeah.
I've had the opportunity to work with teams that have been able to evaluate strabismus or the misalignment risks and how we intervene, or what we're learning about that, the glaucoma, onset and management, a variety of aspects. But one of the more landmark studies that's recently come about is called the infant aphakia treatment study. I have a slide kind of documenting or showing how this was a study done at premier centers around the country, and I had the opportunity to do that. And on the right, it shows if you take out a cataract, you have to replace the focusing power. And that's either done with, as we'd already talked about, the lens insertion on the right, or if you can't do that because the eye is too abnormal or the child's too small in some situations, then you replace the focusing power of the lens with a contact lens. So what the big study you're referring to did is it enrolled infants 1 month to 7 months by selected surgeons across the country to enroll 114 children. And half of them got the lens on the inside and half of them got the contact lens care. And we've been caring for them through our National Institute of Health study for years. Most of them now are turning 10 or beyond. And we're learning more and more about aspects of what does a lens in an infant do versus a contact lens. And I think it's changed care in ways that we're continuing to learn about, but around the world has been a landmark improvement in terms of our care of infants with cataracts. That being said, there's a lot that is yet to understand, and so it's and I here at Mayo and other locations, opportunities to continue to figure out how can we yet do better managing these tough little eyes and blessing these wonderful little children.
How has it specifically changed the care of infants with cataracts? What have you learned from that study? So
the study came after the appreciation that the lenses we use in adults in the 1990s was a good thing, and they were using it in younger and younger ages. So that study said, well, why not babies? Let's put them in the youngest kids. And so that's why we chose the 1 month to 7 month age group. The outcomes for vision are largely equal. I think that's mostly dependent on patching. But the outcomes, the complication rate was higher with the lens. So unless there are reasons why you need to do an intraocular lens and cannot do contacts, most centers that are equipped like we are here choose contact lenses for infants and later put the lens in at an older age versus older children can get the lens primarily.
Earlier you had mentioned, certain risk factors. One of those is Marfan, and that they're at risk for development of cataracts. How do you go about treating their cataracts, and is it different than a child with maybe a different type of congenital cataracts?
So Marfan's eyes have that M&M structure is shifted. I have a picture that talks about that, and that has kind of these shows these special anomalies. And this is reveals that. Up on the top are the pictures you'd see from the front of the eye, and the bottom is that red reflex. Okay. And what you see here is the whole lens, much like the eclipse we just had, where it is shifting out of the way, and the structures that hold it are stretching. As you see in the middle picture on the top three, you see these little fibers, and these fibers typically hold the lens in place like a trampoline is held in place with the strings on the side. But in conditions like Marfan's, and there are others, they are not healthy enough to hold the lens in place. And as the lens shifts, we have to manage that optical problem differently. Some of these eyes have cataracts, but all of them have special lens situations that may need removal. When you manage these eyes, you have to figure out, can I keep the candy shell, or does the candy shell have to come out? And if the candy shell can't hold a normal lens, you have to put that lens in a different place. I have another slide that shows kind of a unique approach that many of us across the United States are using and researching. And so instead, this is a lens that's instead of put back in that candy shell in a normal spot. If that's not an option, we can put them in places like this, that's actually in front of the iris with little tiny clips that pinch to each side of the iris to hold the lens in place. Wow. This is one of many techniques that are options in these complex eyes, and this is part of an ongoing research study that is evaluating what are the long-term risks with this approach. And although there are people that will put these different approaches in children, it's wonderful when we can do these rather newer approaches in a way that helps us make sure it's safe long term.
Yeah, that was my next question: is how long would that be able to stabilize the lens? Do you guys know how long some of these techniques are able to hold the lens in place?
That technique has been around for many, many decades. Oftentimes, mostly used in Europe and around the world. Most of these eyes tolerate it beautifully. And long term. However, as just like I spoke about the lens integrity, we don't know what the 80-year plan. That's where doing some of these studies and monitoring in ways that are a little bit different and follow-up are important for families for safety and security.
Okay. What in congenital cataracts and young babies, there's been mention of use of stem cells to kind of help regenerate the lens itself. Can you talk a little bit more about that?
It's a rather newer approach. We get asked about what's coming, what's different, and some of these things people hear about even online, and stem cells are having profound impact, or the utilization of modification with that throughout medicine, and doing it ethically and appropriately, and how that might complement a disease state. There was recently a report of utilizing the normal lens stem cells that are there in the earliest months of life in a baby. So not necessarily putting something in the eye, but as you take out the cataract, doing it in a way that salvages the stem cells that are there and still have an opportunity to grow, eliminate the cataract and let the opportunity to grow to still fill out that M&M shape. And that was reported. There's a lot of, I think, outcome-based research that's needed to prove that's better than what our current outcomes are. And we look forward to as a field, delivering that sort of outcome over time.
Do you have any pictures of that to show?
I think I brought.
I think we do have one. Yeah.
So this is an example of, on the lower right, that red reflex, and you see what you see in the 1 week, 3 months, 6 months, this little dark spot up in the pupil, and that's the size of the incision. So instead of making a big opening in the candy shell, you make a small one, and you suck out much of the lens. And you'll see in the upper left, there's a little flat line. This is a cross-section across the eye. And instead of having a thick lens, it's really thin. But next door to that is the picture that says 6 months, and it's gotten thick again. So in the youngest infants, that chocolate tends to regrow. And this is an option of, might that be useful, rather than debulking it all. And yet, again, some of these things are hot to talk about, but yet need vetting and long-term outcome.
Right, because you wouldn't want to do something that potentially would have harm later, right?
Potentially.
Especially if you already have something that could fix the vision right
Exactly.
then. Yeah. And so you're still having time to develop that parts of the pathways of the brain that are so important for the vision development. Well, we're reaching towards the end of our time here, but I was curious if you could tell us about any resources that you would recommend for families or websites that you find useful in your practice.
Our national organization called APOS, the American Association for Pediatric Ophthalmology and Strabismus, has a website with resources about cataract. There is a Pediatric Glaucoma and Family Association. I mentioned how often glaucoma and cataracts run together. So those are two that I often direct families to. I also try to make myself available for anyone that wants to reach out to me directly. My email is bothun.erick@mayo.edu, and I'm happy to address things in management individually. And the unique thing is, each child's situation is so different. You need to have the history, the capability, the insight, and even a bedside manner to approach a family in a way, because this is a long-term journey with them to rehabilitate their child's vision.
Absolutely. I bet you get to see a lot of children grow up over.
That's
graduate, go on to college, do all the things that you want them to do, and be successful.
It's a stress to hold some of these little babies down to get the look, but to see them come in and give you big hugs when they're 5 years old, and you get to play with them through the exam visually to get the information. It's a joy.
Absolutely. Well, it was a pleasure to have you here today.
Thank you.
Thanks for bringing all the slides and pictures. I think those are really helpful.
You bet. Thank you for the honor.
Awesome. Thank you. Join us for our next Ask the Mayo Mom, which will be on September 7th at 11 a.m. We will be discussing pediatric cancers in children, and Dr. Ward, who is a pediatric hematologist oncologist, will be joining us. It will also be Children's Cancer Awareness Month. So please join our conversation and send your questions both before or during the broadcast. And thank you, everyone who joined us, and have a great day.